But we're going to have the session, Telemedicine Initiative in Japan, number 2. And this session is, the chair is T. Chun Jiang from the Taiwan National University, and Dr. Tomohito Moriyama from the Kyushu University Hospital.
Sorry. Okay, thank you for this introduction. So we are a little bit behind the time, so we'd like to start our session immediately. So I'd like to invite the first presenter, Dr. Rikako Sagara, who will talk about an overseas remote second opinion. Right. Okay, the time is yours.
Thank you for your introduction. Good morning. It's a great honor to be able to speak to you today. I'm Rikako Sakara, a dedicated physician at the International Patient Support Center, IPAC. Today, I'll be discussing one of the primary activities in which IPAC has been involved, overseas remote second opinions. Here is the outline of my presentation. The Kyushu University Hospital International Medical Department consists of 3 pillars. OBEX provide medical staffing and training, TEMDEC for remote education and developing technology, and we IPAC are in charge of receiving international patients and providing interpretation and translation services. The IPAC has a total of 8 members. A director, a deputy director. He's also a director for the Center of the Study of Global Infection. I myself, a full-time physician, 1 each English and Chinese interpreter, and administrative staff. We accept patients in the cooperation with the allied healthcare staff and doctors of each department. In 2017, our hospital acquired JMIP accreditation, a system developed as a national project to promote smooth acceptance of international patients. We were the second in Japan and the first in Kyushu to be certified by JMIP as a national university hospital. So here is a slide of business results for IPAC over the 6 past years. It's been increasing every year. So how can international patients access the Japanese university hospital for advanced medical care? In order to support overseas patients and Japanese living abroad to visit hospitals in Japan more smoothly and safely, the National University Hospital Medical Corporation Network, we call MedConnect, was established. Currently, 21 university hospitals are registered, and we've been serving as its main office. So now I'd like to take you through the brief yet impactful journey of naming National University Hospital Medical Corporation Network. So we faced the challenge of the lengthy name and reached out for help from ChatGPT, and ultimately decided on the concise and catchy name MedConnect after considering several options. So this is the homepage of the network. Patients click this button to enter their basic information. The basic information should include items shown here. Based on this information and patient's wish, IPAC will consult with the National University Hospital or relevant departments in Kyushu University Hospital. This slide presents the number of patients who came to Japan from overseas via MedConnect and were accepted for the consultation. The number of visitors decreased significantly due to the restrictions of COVID-19 for about 3 years since 2019. The restrictions had finally been relaxed, and the number of patients has gradually increased since last year. The patients are listed by nationality. So now let's get down to the main point. I'll talk about overseas remote second opinion that we are working on. We consider that this could be useful for patients and their families who want to hear the opinions of Japanese doctors, but are unable to come to Japan due to their general condition or for other reasons. In 2017, our hospital started operating overseas remote second opinion after a request from a Chinese intermediary. So, however, we had conducted only 4 cases over the 3-year period since 2017. The reasons for this that there were a few referrals from intermediary agent who requested the service in the first place. Many patients still prefer to actually visit the hospital and see the doctor in person. And some patients were unable to provide a secure internet connection environment and location to conduct overseas remote second opinions. Under the circumstances, international travel had almost come to a standstill due to COVID-19 restrictions. And online systems were rapidly becoming popular around the world as communication tool. In addition, we received a request from intermediary A for 2 hospitals in China to remotely consult with our doctors about their cases, and three trials were conducted, which proved to be a meaningful time. Considering these factors, we had decided to actively promote this initiative starting in July 2022. So here we present the overseas remote second opinion process. Patients or intermediary enter the patient's basic information into MedConnect. We request translation of information such as treatment progress and test data of from home country into English or Japanese. Based on these details, IPAC will consult with the doctors in charge of globalization according to the disease, and if feasible, coordinate the schedule. Temdec always conduct a pre-test to avoid connection problems. The actual session will last no more than 1 hour. And after the session, the doctor will prepare a written opinion in Japanese and send a translated version to the patient to complete the process. Now let's take a look at an illustration of overseas remote second opinions. To ensure smooth and safe implementation, we have set up a system. The first step was to create an explanatory consent form. We wrote a text of our doctor's disclaimer, protection of personal information, and other statements. We prepared both Japanese Chinese and Japanese English version of these documents. Next, a flowchart of overseas remote second opinion procedures were developed. Procedures to be performed by each division are indicated according to a time schedule. This helps prevent errors such as forgetting to check. Next, an evaluation report after each overseas remote second opinion was prepared. By identifying problems and discussing countermeasures, we aim to ensure smoother operation in the next session. Here we present our experiences of overseas remote second opinion conducted over the past year. In total, there have been 10 cases, with most of them being Chinese cases through the contracted intermediary. In October of this year, we also conducted with patients from Korea and Netherlands on a trial basis. The consultations were for a variety of diseases and involved cooperation with doctors from many different departments. The case circled in red on next slide. A Chinese boy with difficulty walking due to after effect of head injury was given opinion by a neurosurgeon at our hospital. So we were able to visually assess the patient with difficulty walking through the monitor. From the way he walked, our neurosurgeon predicted type of paralysis and presented treatment options in Japan, which was explained to the patient side very carefully over the course of the session. After the session, we have received the email of appreciation from patient side and positive feedback from responding doctor. And so I myself specialize in diabetes mellitus as well as a doctor at IPAC. So that was a great experience for me to spend an hour reviewing cases from other medical fields. So with each case of overseas remote second opinion comes issues as well. Firstly, after the start of the session, new materials and new questions were added by patient side, causing the session to last more than 1 hour. Secondly, there was a problem of interpreting. When dealing with for non-Chinese, non-English speaking patients, it sometimes takes time to understand what they said. Thirdly, about the operation of fee structure. The cost for non-intermediary services has not yet been determined, so in that case, it's still free. Finally, there was a case that even though there was no problem in the pre-test, the connection wasn't working on the day of the event due to weather issues, and the session started 1 hour late. In response to each of these challenges, we implemented the following measures. For the first case, we requested that all materials and questions be submitted in advance. For non-Chinese and non-English speakers, we basically ask the patient side to prepare an interpreter. But if there are still any concerns about communication, we are considering the use of three-way calls through the medical interpretation service, which supports 30 languages. For setting the fee, we expect to operate by the end of the fiscal year, hopefully. For the connection programs, we request patients to stand connecting at least 15 minutes in advance. We need to increase the number of connection options. And when natural disasters make it unavoidable, we will be flexible to change the schedule, including the doctor's decision. So regarding the future of overseas remote second opinion, we anticipate increasing demand for it, such as pre-visit interview and post-treatment follow-up consultation. This allows our doctors to understand the patient condition and wishes in advance, while helping the patient to receive our doctor's opinion before coming to Japan. We will continue to develop a more appropriate system for overseas remote second opinion. And when we find a case that may be applicable, we will actively encourage the patient and doctor in charge to respond to changing needs of international patients. Thank you very much for your kind attention today.
Thank you, Sagara Sensei, for introducing us and our new challenges on the doctor-to-patient telemedicine. Okay, so is there any question and comments from floors or online participant? No? Okay, all right. Yeah, I just would like to ask you about the needs Now, maybe most of the people can move everywhere if they want. But so is there any changes on the needs for this kind of activities before and after the pandemic?
Thank you for your question. So, uh, so I'd like to make sure I understand correctly your question. So, you mean about change needs after pandemic?
Right. Yes, yes.
Or for overseas remote second opinion. Thank you very much. That's very important point, I think. So, with lifting of COVID-19 restrictions, we expect an increased number of patients wanting to visit our hospital in person. However, so we believe that pre-visit, so this service as pre-visit interview holds particularly significance. So this approach provides doctors with the ability to understand the patients about the patient's recognition about their diseases and desired opinion, desired treatment, their treatment, and while allowing the patient to receive our doctor's insights about their treatment options.
Okay, thank you. They're using this telemedicine as a screening, whether they better to come to us or not. All right, okay, understand. Thank you so much. Okay, any other question or comments? Nothing? All right, so then we'd like to invite the next speaker. Thank you, Dr. Sagara, again. Okay, next is Dr. Funakoshi. He will talk about new challenges not only in Japan but in the world. The decentralized clinical trial. He is a kind of leader in these activities in the Kyushu University Hospital. So, Funakoshi Sensei, floor is yours.
I would like to talk about collaboration of clinical research core hospitals in Japan to introduce and prepare for decentralized clinical trials. First, I would like to say about medical care uniformity in Japan. Japan is said to be we achieved uniform medical care in this country. Some research showed access to the healthcare is 11th out of 195 countries in 2015. But is that true? Basic medical care is evenly distributed. For example, number of hospital beds per 100 population. The lowest is like Chiba Prefecture or Saitama Prefecture, and the most is Kochi Prefecture. The disparity is about 10 folds. And hospital facilities is about 10 folds. But the specialties increase, the disparities, the number is folds change. Like surgical specialties is less than 10 folds, but like gynecologist is over like several 10 folds, like 70 folds. And oncologist is about like over 10 folds. And training facilities for accredited by the Japanese Society of Clinical Oncology, it's over 100 folds between prefectures. And investigation of new drug clinical trials are much unevenly distributed. Tokyo Prefecture, there are lots of clinical trial sites, but other prefectures is small density. The disparity is about 1,000. So in Japan, regional disparities in general practice are relatively small, but as specialization increases, and it's in its uniform ultimate form, access to experimental treatments, investigation of new drug clinical trials is unevenly distributed. So, like standpoints of patients, some patients who have cancer, and after standard therapies, but the cancer relapsed again and again. So my doctor suggested me a palliative therapy. So those patients, clinical trial is the last hope for survive. But but clinical trials sometimes is undergone only in Tokyo area. So those patients have to use airplane to go to the clinical sites. So the solution is a decentralized clinical trials. Classical clinical trial center is a hospital. So patient is visiting hospital, doctors come to hospital, nurses is working at hospitals, and investigation drug delivery is delivered from hospital to hospital. But a new style of clinical trial named decentralized clinical trial, patient is in the center of a clinical trial. Doctors will approaching to patients like using devices or telemedicine, and nurses is visiting home and investigation of drug delivery from hospital to patient's home. So at the beginning of fiscal year 2022, we heard of decentralized clinical trials, but we don't know how to start. So we started initiatives. Our proposal was adopted by Japan Agency for Medical Research and Development last year and this year. So I was in charge of working 1, and Dr. Moriyama is in charge of working 4. Core clinical research hospitals, there are 15 hospitals in Japan. The Ministry of Health accredited 15 core clinical research hospitals in Japan. So we had a network, and we propose first we would like to develop and deploy the digital tools to enable clinical trials efficiency and decentralized clinical trials. And also we propose to develop operational procedures and check the flow line by simulation with mock patients. We pick examples for decentralized clinical trials to be prepared and develop scenarios. So technology and human also important. So simulation number 1, we pick acute infectious disease like COVID-19. We build a scenario like a fever outpatient clinic. Some patient tested like a PCR, and the test was, if the test was positive, local local hospital said to patient that if do you want to take like a clinical trial, new drugs, and the patient said yes. The clinical trial site doctor approaching the candidates and using telemedicine, explaining about the clinical trial, and the patient had a consent remotely. After consent, after the patient had a consent, screening test was performed at a local hospital. And after enrollment, the patient is hospitalized in a clinical site. But after discharge of the clinical site, the patient go back to home, and some visits were performed by a local hospital, and some visits are performed by visiting nurses. The second scenario is easier for slowly progressive neurodegenerative disease. This time, we use local hospital, family physician, and a clinical trial sites. Using telemedicine, we try to obtain consent from patients using telemedicine, and after consent, the patient comes to our clinic first, but after the initial physical checkup, the patient go back to home, and using investigational drug delivery, the patient can take a new drug at home. So this is a flow. So after building up those scenarios, each hospital performs a simulation training of DCT based on a common scenario, and some using like some mock patients. What we learned first, each combination of disease and investigational drug has a suitable DCT. There are several elements of DCTs. So different style of DCT exist, from classical clinical trials that do not employ any elements of DCT to full DCT. It's a gradation. And delivery of investigation drugs for acute infections is too time consuming. So like COVID-19, we choose, we didn't choose drug delivery. The patient have to come to a clinic first. And second thing we learned, a tool is just a tool. The process of consulting and deciding how people should move in DCT is the most important thing to prepare for DCT. Such as system, this is a fancy system. So using this, patient can enter symptoms on a smartphone. But we have to decide who explain the system to patient participants and who is the help desk, and when and how to register the participants to the device. Such as operation is very important. And the third thing we would learn, if we use DCT specialized visiting nurse station and investigation drug delivery companies, the costs will increase significantly. We estimated the cost for 150 subjects, and for drug delivery, it's over 50 million yen. It was too expensive. So yes, it's expensive. So there are pros: reduce burden of patients and accelerate recruitment and shorten overall study duration. But there are cons. So like variability in measurement methods or like costs. So this is my conclusion. And also I would like to emphasize trust is important for DCT. Thank you.
Thank you for introducing the decentralized clinical trials, Dr. Funakoshi. So is there any question and comments from floor? Right. Okay, Dr. Shimizu.
Thank you very much for the nice presentation. So this is just the information for the participants here. So his team is quite energetic in the field of the clinical trial here in Japan. But now they are going to go out of this country and to seek for the possible collaboration with other countries in Asia. So the next month, in the middle of next month, as the first target country, not he himself, but his professor and the two other lady professors will visit Malaysia and make a stopover at the to have some discussion for the first place. And they may visit other countries like Thailand or Indonesia, India, I don't know. But we do want to expand their research around Asia. So please, if someone interested, just get in touch with them and his team. And I appreciate your cooperation in advance. Thank you very much.
You consider Australia.
Okay, thank you. Comments or questions? Right. Okay, then I have one question. So, as I suppose, surely you have many problems to be solved to install this DCT in the clinical setting, not in Japan. So, but what is the most difficult issues to install this DCT in Japan? Just an opinion is okay.
For investigational new drug clinical trials, there are very strict rules. So researchers and doctors are very, you know, 保守的はなった。I'll say yes, conservatives. So some doctors say classical clinical trials conducted in a hospital, it's enough. So but some radical doctors are trying to change. The patients are we have to so patients outside of Tokyo area, we have to give their hope. So even some doctors are too conservative. I think we have to progress.
Okay, thank you. Okay, all right, cool. Right, shall we? Right.
Okay, so I think this decentralized clinical trial is an idea that will work. Perhaps not at the international level. Maybe because the conventional way is the research will normally recruit the high volume centers from each country to participate in the trial.
Mhm.
And then once the high volume center is selected, maybe this decentralized will work if it is selecting patient from the same country, because patient from other prefecture may be too far away to come to the referral center to participate in the trial. What do you think? So I think perhaps it will work at a national level, DCT. But if it is a cross country, perhaps, like you say, the cost of a delivery of the drug will be too expensive.
And for international clinical trials, I was in regulatory agency for 2 years, like about 9 years ago. International clinical trial is very important for approval of new drugs in each countries. So if the clinical trials is performed in each countries, industry have to pay a lot of money to develop a new drug. If they conduct one international clinical trials, the cost is one clinical trial cost is big, but in total they can sell drugs in many countries. So finally they get benefits. For new drug development, benefits for industry is also important. So as you know, so if conducted clinical trial, international clinical trial in DCT style, it can be a bit expensive, but in total, it's beneficial, I think.
Yeah, see your point. Thank you. I look forward to welcome you to university.
Okay. Okay, thank you very much, Doctor. And for the interest time, we have to continue for our next talk. So you can meet in face in person. It's okay. Yeah, if we for the catch up time. So yeah, no time. Sorry, but you can discuss it on site. Thank you. Okay, for the interest of time, we have to catch up our time. So the next speaker also online, and we will invite Dr. Kurioki and to present the telemedicine in Japan, the future and the present and the future. Dr. Proisia.
Yes.
Yeah, thank you.
Thank you. Okay. Can you see me my slide?
Yes,
Okay.
we can see.
Okay, thank you. Hello, everyone. My name is Haru Kuroki from Paurum Clinic for Children and Parents. in Aoyama, Tokyo, Japan. It's a great pleasure for me to be here today. I'd like to thank Professor Moriyama for giving me this opportunity. Today, I'll introduce the present and the future of telemedicine in Japan. I will propose these issues from the viewpoint of my primary care medicine and from the general point. I want to start by saying that there is no COI in this work. Before my presentation, let me give some more background about myself. I'm a pediatrician and run a pediatric clinic in Tokyo. I am a board member of the Japanese Society of Telemedicine, a member of the Ministry of Health, Labor and Welfare Study Group, and a member of the Japan Medical Association Study Group. I manage a clinic from 2005 to March 2023 in a rural area in Chiba Prefecture. I have been implementing telemedicine at my facility since 2016. I have been utilizing it for my patients, including those with COVID-19. I'd like to introduce my clinics. This slide shows the location of my clinics. I run a pediatric clinic in Izumi City, Chiba Prefecture since 2005. And I opened a new clinic in Minato Ward, Tokyo in April 2023. Before I talk about the future of telemedicine in Japan, I want to introduce the actual result of telemedicine at my clinic. At first, I introduce the achievement in my past clinic in Chiba, Izumi City. A total of 7,409 patients were treated by telemedicine until March 31st of 2023. In the location of the clinic, there is a small number of doctors. Secondary medical facilities are 50 kilometers away. The normal medical care area is within a 30-kilometer radius. We have been providing telemedicine in this station since 2016. The most common disease among those treated by telemedicine are acute upper respiratory tract infection, allergic rhinitis, bronchial asthma, and neurodevelopmental disorders in children. The number of patients with COVID-19 has increased rapidly since the advent of the disease. And along with the medical examination of children with COVID-19, we are seeing an increased number of families together. This data shows the indication of telemedicine is the same as usual face-to-face medicine. Particularly, neurodevelopmental disorders and acute infectious diseases are suitable for telemedicine. Next, I show results of telemedicine at my current clinic in Tokyo. A total of 389 patients were treated by telemedicine from April to October of 2023. This clinic is located in the center of Tokyo, and patient access is not limited to the local area. The patient breakdown of telemedicine in this clinic are mainly allergic rhinitis and neurodevelopmental disorders. This reflects the daily practice and characteristic of this clinic. After October of this year, flu and COVID-19 have been increasing, and I have examined patients with these acute infectious diseases by telemedicine. Now, I'll mention the public health in Japan. The average life expectancy in Japan is one of the highest levels in the world. Furthermore, the neonatal mortality rate is extremely low. Medical care in Japan supported by national insurance has free access for all people. Citizens can receive good quality medical care anytime and anywhere at a low price. Public health in Japan is excellent. So some doctors say telemedicine is the method for underpopulated areas. So telemedicine is not necessary in Japan because Japanese primary care is one of the best all over the world. It is enough. Actually, medical care in Japan is excellent, but I don't think telemedicine is not necessary in Japan. It could make Japanese community medicine better than now. Telemedicine is necessary for the future of medicine in Japan. The most appropriate telemedicine for Japan should be explored. What is the future vision of telemedicine in Japan? There are three advantages of telemedicine. One is the accessibility. Telemedicine is useful not only in rural areas, but also in urban areas. A parent with a febrile child is hard to go to a clinic when a parent themselves are not in good condition. For example, in the case of COVID-19 or flu, and not being face-to-face has excellent advantage for both patient and medical staffs. Second point is information. Doctor can get more useful information by access from patient usual lives. Third is patient participatory medicine. Finding in patient daily lives enables them to actively participate in the treatment. How is the new technology contributing to medical care? After this slide, I will demonstrate specific instance of these advantages of telemedicine in Japan. Japanese telemedicine technologies are active in remote medical care. This video shows the transport of drugs by a drone to remote island.
通院が難しい地域、簡単には薬を受け取れない地域、どんなに医療が進化しても全ての人に届かなければ意味がない。武田が構想する次世代地域医療プロジェクト、志を同じくするあらゆるパートナーと手を組んで実用化に挑む。
New technology is not only for remote area. Robots can also be used to deliver drugs in urban areas. It will be helpful for patients with mobility difficulties. What about telemedicine's contribution to the prevention of endemic of infectious diseases? This slide shows a nucleic acid testing method. With this method, compact testing machine can be distributed to different regions. They can be placed in any area, accommodations, gathering places such as concert halls, theater, and homes, even at airport or on board ships. It can be tested on the spot. The data can be digitized and sent to medical record. The diagnosis of infectious diseases will be possible everywhere. Patients with acute infectious diseases can be treated by telemedicine anywhere they are. Rapid and appropriate medicine will be realized. It can prevent and predict endemic of infectious diseases. As such, the smart medical city will be realized. This is another telemedicine system. It allows information to be transmitted by the patient. Input forms for various physical and lifestyle items are standardized and can be set up flexibly. Automatic data collection in conjunction with wearables and other devices can be developed. Patient participatory medicine is one of the purposes of telemedicine. This telemedicine system allows auscultation and getting pharyngeal findings from home. The data is digitized and can be sent to a doctor. With this method, families and residents can access the service of the medical doctors from their home. Even acute cases can also be connected. This is called the best remote primary care.
The clinic has come home. Finally, families everywhere can enjoy the best remote primary care we all deserve. Home Smart Clinic by Taito Care.
In providing home hospitalization, biometric information should be obtained non-invasively and continuously. This is electronic skin, the ultimate wearable devices.
I'm Takao Somea, a professor at the University of Tokyo. Our on-skin sensor utilizing nanomesh electrode is ultra-thin, lightweight, stretchable, and breathable. It is capable of monitoring health conditions simply by pasting it onto the skin. New sensor can be worn on the skin continuously for a week without causing any inflammatory issues. Our skin display is a 24 by 16 array of micro LEDs, and it exhibits simple graphic with motion because it is made from thin and soft materials. It can be freely deformed. The skin display also showed an electrocardiogram measured by using nanomesh electrodes. Combined with a wireless communication module, the acquired biometric data can be transferred to a medical cloud, and your home doctor can monitor your health conditions while you stay at home. In the future, we envision human-friendly skin electronics that will lead to improving the quality of human life.
Given all this information, I want to share what I think we can do for the future of telemedicine. I would like to propose a new concept of medical treatment mode. That is a new medical network. In home hospitalization, patients can receive medical care wherever they are, and medical professionals gather there. We believe that the current telemedicine is the first step toward realizing such home hospitalization and the best remote primary care. this medical network impact on the future of medicine. This slide shows the concept of the future medicine realized by telemedicine. P for medicine is the purpose of telemedicine. Furthermore, I want to emphasize that medical professionals need to incorporate new technologies themselves and propose new ways of using them. The Japanese government has already had the vision of telemedicine. The guideline shows the principle of telemedicine. It is such as patient-oriented medicine. Before I close this presentation, I want to share with you what inspired me to discuss this topic. An elementary school boy who was my patient said to me, "Doctor, you use telemedicine in your clinic. I know what telemedicine is." And he showed me his textbook. So I made this slide. In the 5th grade elementary school textbook in social study, medical IT is taken up. So Japanese children already know what medical IT is. Therefore, we should focus on developing telemedicine even more. This is my current clinic in Aoyama, which has a library for children and parents. We have 2,000 books which is available for checkout. Literacy from good and classic books is important for children and parents. So I established this clinic. With excellent literacy, we can use new technology. If not, technology might use us. Thank you very much for listening today.
Okay, thank you. Give a big roll for Dr. Korioki. So thank you for your very inspirations talk. So any question? I believe there are many questions. So any question from the floor? Or online? No, no question. Wow. Oh, yeah. Doctor from Australia.
Thank you, Doctor. Very inspiring presentation. Very futuristic, future-looking ideas. While you're talking, it reminded me some of the things that we have been thinking about, talking about, doing some research in Australia at the Center for Online Health. Remoteness is a big problem in Australia, which I thought is not a problem in Japan. But you convinced me today that there are remote areas where disparity is a problem in terms of healthcare, and telemedicine is some way of addressing that problem. You mentioned that you have been practicing telemedicine for a number of years. When I spoke to my colleagues, Japanese colleagues, long time ago, I've been in the field of telemedicine for 20 years. So I have colleagues in Japan. When I spoke about telemedicine practices in Japan, one thing they always mention is the privacy, security, confidentiality type of things are really, really difficult barriers in practicing telemedicine. Yeah, certainly privacy is a big problem everywhere when it comes to healthcare. But what my Japanese colleagues convinced me is that Japanese people are extremely concerned, extremely sensitive in relation to privacy. So that's a great barrier. So how did you overcome in your practice this major barrier to integrate your telemedicine into your practice? Thank you.
Okay, thank you very much for your question. Your question is, I think, 2 points. One is Japanese distribution of medicine. Two is telemedicine risk, such as security, privacy. Yes, my answer is that at one point, Japanese medicine distribution is not even. I had managed in rural few doctors area in 18 years, my own clinic. There are no pediatric specialty around 50 kilometers. The patient with emergency disease has to go to emergency clinic about 1 hour by emergency car. So I think Japanese medical distribution is not even. And now I managed my clinic in the center of Tokyo. Thus, in that area, the medicine is too much. Yes, that is the problem of my, I think, Japanese medical situation. So for remote area, telemedicine is necessary for Japan. The second point, the barrier of telemedicine in Japan. Now, especially after COVID-19, almost Japanese people don't afraid of security or risk by web conference now. But now there is barrier for telemedicine in Japan. That is 2 points. One is the inefficient regulatory. Japanese telemedicine price is lower than usual medicine. Two is all Japanese people, doctor and residents, has quite a strong thought that it is okay as it is. But in Japan, during COVID-19, many people died in their home. Even though it's a fact, they think it is okay. It is another problem, I think, in Japan.
Yeah, thank you. So any more question? Okay, if not, thanks for all the four speakers. Let's give a big applause for all of them. And thank you very much for joining us. And we really have a great, wonderful time. Thank you. Okay.
Thank you very much.
Session will be closed and I'll give microphone to our master of ceremony, please.